three main causes of varicose veins are standing on your feet, pregnancy, and hereditary. Heaviness, restless leg syndrome, extra fluid in their legs, edema, swelling, little aches and pains, cramping, those are all different typical symptoms of vein disease, or we also use the term chronic venous insufficiency, meaning the veins are insufficient. They're not carrying the blood back to the heart. But sometimes it can be, since it is such a slow and insidious process, sometimes the symptoms aren't even picked up by the patient because this happens over 5, 10, 15, 20 years. So sometimes they don't even notice that their legs are heavy or that they're carrying around extra fluid in their legs or that they have edema in their legs. It comes in all age ranges, but the main patient, the typical patient, is a woman in her late 40s to 50s who's had children. But we see this in teenagers, we see it in 70-year-old patients, we see it in men, we see this a lot in biathletes and triathletes, men who work out a lot, who have muscle hypertrophy, which then that prevents the blood from emptying from the outside the muscle to inside the muscle, causing a high pressure gradient, which causes the valves to break, which then causes the chronic venous insufficiency. So we see it in all types of patients, and nationally speaking, about 1 in 8 people who have vein disease. I would say about 70% of the patients are females because the number one cause more so is having children. That pressure from the uterus on the veins causes those valves to break. So afterwards, after your valves are broken, then the veins don't empty properly. The veins are supposed to be flowing back to your heart. This darker blue vein is your deep vein. Now, this is not drawn to scale, obviously, but that darker blue vein carries 95% of the blood back to your heart. When it meets pressure from, let's say, a uterus, there's pressure back buildup, and it can damage these valves in this lighter blue vein. The darker blue vein is your deep vein, and it's sitting around your muscle, so the muscle helps propel the blood back to your heart. The lighter blue vein depends on these valves for it, kind of like an elevator shaft, to bring the blood back to the heart. When these valves are broken, then the blood can't be returned back to your heart, and it just acts like a waterfall effect on that lighter blue vein, which is called, in this case, the greater saphenous. There is also a short saphenous as well on the back of the leg behind the calf. Those are the two main veins which are injured from chronic pressure from above. The first thing we do is we do an ultrasound of the legs. We have to map out the veins and determine what needs to be treated. Okay, after that, then we set up a treatment plan, which mainly consists of treating with 2 different modalities. One is something called venous radiofrequency ablation, similar to a laser. And the second is ambulatory microphlebectomy, which is if a patient has large enough bulging veins, we will actually physically take little pieces of those veins out to kind of clear it up at the very end. From having varicose veins, that can cause stagnation of blood in these pools of varicosities, so you can get blood clots within the varicosities. You can get something called thrombophlebitis, which is inflammation of the veins that occurs in these varicosities. You also can get swelling, discoloration of the skin, as you see in these diagrams. These are all different complications of varicosities, change in color of the skin, thinning of the skin, and even ulcerations. If you have enough fluid buildup in your legs over time, fluid on your heart causes congestive heart failure. Extra fluid in your skin can cause skin failure, and you get an ulceration, and then you have a big problem. The problem for the ulceration is these things are hard to fix. Okay, your skin is your protective barrier against infection. If your skin is injured, you've got an opening for an infection. So you can get an infection, or you can have bleeding from the wound. There's a number of different things that can occur at a wound site. Obviously, we don't want to walk around with wounds on our body, but in particular, we call these types of ulcers venous stasis ulcers, are extremely difficult to fix. So we don't ever want to get to that point where we're trying to fix the venous stasis ulcer. We want to prevent it from happening. And the insurance companies have realized this. That's why they treat this under medical insurance, because they know if we get to a venous stasis ulcer, it's going to cost millions of dollars to fix, instead of preventively just fixing them when they're at the varicose vein stage and get them fixed preemptively. If their symptoms have been there for 10 years, it might take a little bit longer. It might take 2 to 4 weeks for them to kind of start feeling that relief on their legs. If it's been a year or two, then it's then sometimes it can be instantaneous. Nationally speaking, when we treat a leg with the venous radiofrequency ablation procedure, the statistics show us about 85% at 10 years. And that means the vein that we treated opens back up, and then we just have to go back in and treat it again. Okay. The nice thing of treating it this way versus the old way we used to do it, which is vein stripping we used to have to do in the hospital, and there was a very high recurrence rate. And the patient, since you're taking the veins out of their body, they would grow new veins. This way, we're actually just leaving that vein in the body, so the body thinks the vein is still there, and we're just getting it to stop leaking. I'd say 97% of patients experience little to no discomfort during the procedure. They feel pressure, they feel little pins and needles. Some people describe it as a blood pressure cuff sensation, kind of a blowing up of their leg. Others describe a little pins and needles, but I've done nearly 5,000 of these procedures. I've never had a patient say they were unable to take it and they needed to stop the procedure. So it's a very well tolerated procedure. There's about 3% of the patients that I will give a little Valium for them to relax before the procedure. I would say 50% of those, after they see how easy it is, don't take any Valium on the next procedure. Okay, so it is a very well tolerated procedure. Doing it under local, and the patients recover a lot better than not having given them in general anesthesia. I do procedures under general anesthesia. It takes them a lot longer to recover from the anesthesia than it does the procedure. So now we really can do these. Patient walks in, patient walks out, gets in their car and drives on out of here. The biggest risk of this procedure are a deep vein thrombosis, a DVT, a blood clot in their deep vein. And that's why when we did the procedure, as you would have seen, me checking before we do the treatment phase of the procedure, I'm checking 4, 5, 6 times that catheter is nowhere near that deep vein, because that is a critical point. Once you press that button to treat near the deep vein, if you treat the deep vein, you're going to damage the deep vein. It's going to cause lifelong problems. I've never had that happen to any single one of my patients, and it should never happen. Nationally speaking, it's about 1 in 1,000 patients get a DVT from this procedure. I've done nearly 5,000 without a DVT, and you really have to be methodical and careful and check 4, 5, 6, 7 times, however many times it takes, and watch on ultrasound. And as you see earlier, I have the patients watch along with me. It's better to have 4, 5, 6 pairs of eyes checking than just the doctor. You can get a thrombophlebitis, you can get a little inflammation in the vein as it's healing itself, causes a little pain, discomfort, redness along the vein, but it'll go away on its own. It's not something that's going to persist. Those are the 2 big main things that can happen from this procedure.